Welcome, everyone, to the virtual Compassionate Action Healthcare Conference. I'm Kathy Scopin, Member Experience Advisor at the Schwartz Center for Compassionate Healthcare. On behalf of all of us at the Schwartz Center, we are so happy that you've joined us for today's workshop, Improving Patient Experience of Care Through Workforce Development. Please join me in welcoming our presenters for this session. Jenny Azara is the Senior Director of Performance Improvement and Organizational Development at the Community Care Cooperative, also known as C3, and also a Senior Practice Transformational Specialist at the HMS Center for Primary Care. Joining Jenny is Louise Keogh-Weed. Louise is a C3 consultant for the Community Care Cooperative and a Practice Transformation Specialist for the HMS Center for Primary Care Systems Transformation Team. Thank you both so much for joining us today. Jenny and Louise, I'm going to turn it over to you.
Thank you, Kathy. Louise and I are so excited to join this virtual conference. It's an honor to share our work, and we are really looking forward to some good conversation with all of you this afternoon. So again, I'm Jenny Azara. I'm the Senior Director for Performance Improvement at C3. And Louise, would you mind just saying hi?
Yeah, welcome everyone. We're so excited to be with all of you this afternoon. I'm Louise Keogh-Weed, and I am, for this role, a consultant with C3.
Next slide. So our agenda for the next hour is to share with you our story about doing patient experience work with community health centers in Massachusetts. We have a number of slides. We're really excited to share the content of our training and what we learned. We also want to hear from you. So we encourage you to use the chat to interrupt us with questions. And we hope that we can generate some good discussion so that we can even take down the slides and look at each other. So if we do take down the slides, feel free to take yourself off video so that we can connect across Zoom land. We'll tell you, so I'm going to keep moving it forward. Our learning objectives are to share our experience of an FQHC-based accountable care organization's approach to improving patient experience through workforce development. That's a mouthful. We'll discuss strategies for shifting organizational culture on customer service. And we'll provide you, hopefully, an opportunity to make connections between self, team, and patient care. And that will make sense pretty soon. So C3, Community Care Cooperative, is a MassHealth accountable care organization. So MassHealth, for those of you outside of Massachusetts, which most of you probably are, is the state's Medicaid program. And in 2018, the state of Massachusetts Medicaid program launched an accountable care organization approach. So in 2016, C3 was formed in advance of that program starting. We had 9 FQHCs, federally qualified health centers, in our pilot program. And when we launched our accountable care organization in March 2018, we were up to 15 FQHCs. Today, we're up to 18, and as of today, like precisely today, we have over 144,000 Medicaid individuals in our program. So an ACO, for those of you who are not familiar, are a group of providers that work together and are responsible or accountable for the total cost of care and quality of care that is delivered. We're focused on high quality coordinated care, and I'm happy to answer questions about that approach if we have time. If not, I think the link to our website is in here. We're also a primary care ACO, so our patients go to federally qualified health centers and where the focus is primary care, inclusive of behavioral health, and for many health centers, oral health services and eye care. But our patients can go to any hospital across the state, any specialist. So we are primary care. If you're familiar with the MassHealth program, we're a Model B ACO. Next slide. Our vision is to transform the health for underserved communities. Our mission is to leverage the collective strengths of federally qualified health centers to improve the health and wellness of people we serve. Our strategy is to achieve a market-leading model of care through community-based innovation, and our core values are social justice, respect, integrity, optimism, learning, and results. Next slide. Here's a map of the state of Massachusetts and our 18 member FQHCs. I know I'm using a lot of terms like FQHC and ACO. If at any point it's too much of an alphabet soup, just someone chat in and let me know to slow down. But the health centers across the state are numbered here. What you can't see is the number of locations. So for example, 16, which is Community Health Connections, which is up in the Fitchburg area, central part of Massachusetts, has 4 locations. So each one of these federally qualified health centers is an entity, with most of them having multiple locations, so they can meet the needs of their communities. Next slide. As a part of the MassHealth ACO program, our members, who are our patients, so we use the term member and patient interchangeably because our patients are members of our ACO, so I hope that's not too confusing, but they are surveyed once a year on the experience of care. I think this survey goes out January to March of every year, and patients are asked about their experience in the prior year, which I think is different than the Press-Ganey approach of how was your last visit. So that's important, just methodology-wise. The initial results that we had from the pilot ACO program was that there was room for improvement in access, appointment access, customer service, and care integration. So the C3 board, and I should say that our governance structure is really interesting. The C3 board is comprised entirely of health center CEOs and CMOs, chief medical officers. So the board looked at these results for the patient experience surveys and said, we want to work on customer service. Access is really hard to manage, and care integration that's a little tricky. So we're going to work on customer service. And I said, okay, let's develop a patient-centered interactions training, because I prefer that term over customer service, and everyone agreed that was a great idea. So our plan was to have a planning time in the summer of 2019, and then we would launch our program. Next slide.
Pause for a second, and we're going to take a step back, and we'd love to hear from all of you. So either in the chat, Jenny's going to manage the chat, either in the chat, or you can just speak out. We really want to hear from all of you what your organization's strategy is for patient experience, what trainings have you experienced, what has worked, what hasn't, what would you like patient experience work to be rooted in? I know that's a lot of questions, but feel free to respond to whichever one resonates most with you. We just want to hear a little bit about folks' experience and what's gone well and not well. I'm going to assume that no one's ever been trained in patient experience and nothing has ever worked, and you don't want it to be rooted in anything. Got it.
Louise, did you want this as a chat, or do you want this as a voice response?
Whatever you feel comfortable with. Matt, I'm going to let you do a response. I love your picture.
Oh, thanks. That's Newfound Lake up in New Hampshire, even though I'm in California. Let's see, organization strategy for patient experience. So we're a pretty good sized health system based in Santa Clara County, which is Silicon Valley out here in California. It's Santa Clara Valley Health System. Patient experience strategy is we have multiple venues in order for our patients to come in and be connected to our health system. About a year and a half ago, we acquired 2 community hospitals. Before that, we still are a large level 1 trauma residency program training center. So We had our own set of clinics, about 11 community clinics that were already in existence. With the acquisition of the 2 hospitals that were community-based hospitals, private community-based hospitals, or actually religious affiliate hospitals that went into bankruptcy and that we acquired. We're now in a set of strategies to try to pull in that set of folks that would normally have been seen at those 2 hospitals. My current job is to open up medical office space and clinics that are connected more to the community level. We also, as a county, have multiple behavioral health, medical side, procedural sides, all that have marketing strategies that are out in the community as well. What trainings have I experienced? We have multiple sets of training on marketing flow processes for trying to get to various community groups in all of the different disciplines of medicine, behavioral health, and wellness is a big focus of ours as well. What has worked and what hasn't. We're on a continuous cycle to look at our strategies and what's gone on with them. To just answer that question you have up there is what has worked and what hasn't. What has worked is the fact that we do have every part of the health system is pointed in trying to provide care to anyone that comes to our doors. We're a safety net hospital that's been providing care that way since its existence, which dates back to the late 1800s. And what would we like patient experience work to be rooted in? I always fall back, I guess I'll answer this from a personal point of view, is I always look at patient experience from the perspective of if it was one of my loved ones and they weren't as steeped in healthcare and how to maneuver through these systems, and I've worked at multiple systems, including in Boston, I always get worried that it's the person that has had no person in their family that's health connected and nobody that knows systems. How do we get them from the front door into the service that they want or need in a gentle but firm pathway that gets them so that they're getting taken care of whatever their needs are. And you just can't do that enough, I think, so that your poor 85-year-old mom will make it from the front door to the eye clinic she needs to go to, or to the cardiology clinic. And and we're all, as we get more and more involved with these things, we look at it and we go, oh yeah, that's easy. You go in, I'll look for the word cardiology. Does the person speak English as a primary language? Do we have it available so that they understand what that is in Vietnamese or Spanish, and et cetera, et cetera. So there you go. There's my answers to the questions.
Thank you very much. I really appreciate you speaking up.
You're welcome.
Other folks, Jenny, things from the chat?
There's some really great responses in the chat, and one organization, or Melissa responded that they have in their orientation and classes, they already built in compassion, empathy, and connection into trainings. And I said they're ahead of where we were a year ago. And I'm really intrigued to hear more about family faculty that Ruth mentioned, having patients and families do training of staff. So if we have time in this call, Ruth, I'd love to hear more about what you do.
Great. Thank you. I'm going to move us forward.
So you may be wondering, how we got to where we are and doing this type of training. It was largely because Louise and I have done a lot of this work in managing, supervising staff in health centers, and doing quality improvement for several years, performance improvement. And we just felt like I wanted to do something different. And then I brought in Louise to help as a consultant. I wanted to do something different. When our board said we want to improve customer service, I felt really strongly and had support of my leadership and board to do something for our frontline staff. And so we started by having a planning phase. We had an incredible intern from Health Career Connections. If you don't know about this organization, check them out. They connect health care organizations with diverse future healthcare professionals. So we had an intern in the summer of 2019 do research for us on like what's out there and improving customer service. What are the off-the-shelf trainings that we could adapt? What could we send our staff to? And when I send our staff, you know, none of the staff that we're training or talking about today report to us at Community Care Cooperative. They report into their health centers. That's really important. So we were, as a central organization and a convening organization in ACO, trying to improve the skill set of frontline staff who didn't report to us. I just think it's an important nuance. So our intern looked at everything that's out there. I know I had trained staff in a previous life in ADET and other communication techniques, and we fell in love with the Language of Caring program. The reason why we couldn't work with that organization, if you know of them, it's a branch of Plaintree International, they're incredible, is that doing the Language of Caring program requires whole cultural shift for an entire organization, and because we weren't at the health centers, we couldn't affect their entire culture. So what we did is that we took the best of the programs that we researched and developed our own curriculum. And you'll see here the highlights, which Louise and I will give you some sample content about. We wanted to talk about understanding burnout and moral injury, how to communicate with empathy, trauma-informed communication strategies geared towards frontline staff, not clinicians. We tested this out almost a year ago, last November, and we started with the supervisors of frontline staff. And we had an incredible all-day session, almost all day. It was like a 6-hour training session in person. We provided breakfast and lunch and brought together frontline supervisors from all across the state and had an incredible response. So with that response, the response from the participants, that is, we were able to plan to train at least 100 frontline staff in 2020. Our goal, things shifted as of Thursday, March 12th for us, with all of the staff of the health centers either having to work remotely or, getting engaged with COVID testing and other chaos that ensued with the pandemic. So we put off the trainings until this past summer, and that gave Louise and me some time to convert it to a virtual format and to be thoughtful about how we were going to recruit and support staff to participate in a virtual training. And you'll see at the bottom, we ended up training 115 staff.
So when Jenny approached me about this training, the thing that really excited me is the thing that Jenny keeps talking about, which is that it really took a different approach. And I, along as I'm sure everyone else on this call, have definitely participated in the really traditional customer service trainings, but they don't feel particularly impactful and they don't get to some of the root cause issues. So we really looked towards, and I really appreciated Jenny and C3 sort of going in this direction, but we really looked at the data that shows that customer satisfaction is directly linked to a happy workforce. Now, that's not necessarily specific to healthcare, but it's true in virtually all industries. So we really pulled from that. Then, of course, self-reported provider satisfaction is also linked to patient satisfaction too, right? And then staff burnout is linked to patient safety issues. So what we could really do was start to think about what are the underlying things that go on that are especially true in community health centers that we can start to get to impact ultimately patient experience as our ultimate outcome. It also pulled from Jenny and I both have a significant amount of experience working in community health centers. So we also pulled from our own experiences, having worked there, and the issues that we saw over time and continue to see over time partnering with community health centers. So we really, admittedly just drew from our own experience. And neither of us are clinicians, I should name that. We've both been in administrative and operations and patient-centered medical home goals, things like that. So we also really wanted to take a different approach in that we focused on frontline managers and staff. And we wanted to do this because we know, again, from our own experience and from some research, that frontline managers and frontline staff have the same experience as providers, but are overall less supported, right? They have less access to trainings, less access to, they're not doing CMEs, things like that. So overall, sort of similar experience, but less support. And even though the research is limited to clinicians, we're not stupid. We know the experience is not limited to clinicians. That's just where the research is, right? So we really drew from that to say we think this applies to everyone. Again, less access to training, resources, professional development. So we really wanted this to be an opportunity for folks to step out of their roles and take some time to reflect and learn, which is not something when you are in the day-to-day of a community health center that you get to do very often. Also, staff often feel undervalued. There are extraordinary power dynamics in healthcare when you're working with physicians and other clinically trained folks. In community health centers overall, folks are working with very complicated patient populations, and there's just generally a challenging work environment. There's some serious under-resourcing in community health centers. And again, we know this both from research and talking to people, but also our own experiences of having to work with a budget of zero for all things that we've been trying to do. So again, I was really excited to get to work with folks who I knew are getting less attention than some of our higher trained individuals. So these are our official learning objectives. We wanted to build relationships between people with similar roles and strengthen the C3 network. We wanted to discuss the highlights and challenges of frontline work in community health centers. We wanted to build a really concrete toolkit for burnout and resilience, trauma-informed interactions, communicating with empathy, and then create a personal action plan for growth and development. We also had these unofficial objectives that I think are honestly the more important objectives. Again, folks who are working in community health centers don't often get to talk to each other, and we really wanted to make space for people to come together and see what the threads are between their work. And I know that when I was in a community health center, I was in a high-level administrative role, and even I didn't get to talk to other people. And I know that the more you are on the front line, the less you get to step outside of the health center. We also wanted to have their work honored and lifted up, right? That they take care of vulnerable communities, and we want to validate their individual and team experience and provide a safe space. So really take time to say, we see you and we honor your experience, and we know that it's challenging and we know that you're good at it. And this is time to acknowledge and celebrate that as much as possible.
Louise, do you mind if I add something really quickly on that slide, the unofficial objectives? Something that helped us reach these objectives was that we had a third facilitator. So Louise and I, after we did our initial training a year ago, we invited one of my colleagues who is a patient service representative at Community Care Cooperative, someone who talks to patients all day, every day. We invited him to join our team. He's actually our lead member services representative, and he formerly worked at one of our health centers for several years. So having the addition on our team of someone who is in the role of talking to patients all day, every day, really contributed to us, again, validating their experience. So it wasn't just Louise and me saying, we hear you, we see you. It was someone who's doing the job just like they are every day.
Thank you. We built everything that we did in these trainings around this visual. So our feeling for all of this work is that you have to start with self. You really can't go anywhere with any of this work until you start with yourself in the work, your own experiences, what you are bringing day to day, what's hard for you, what's easy for you. And then that interacts directly with your team, right? And what all the individuals on your team are bringing to work every day, and then what your team dynamic is overall. And then that ultimately interacts with the patient. But again, we wanted to step away from the more traditional model of just having it be all about the patient, not that it's not all about the patient, but to say that in order to get to the patient, you actually have to work through yourself and your team, and then that is how you're going to impact your relationship with the patient over time. And I'll show you, you'll see, you know, it's also again acknowledging we're all humans, right? We're coming to work with our own feelings. Our teammates are coming to work with their feelings and experiences, and so are our patients. And all three of those are interacting all day, every day. And until we can lift that up and make the implicit explicit and then work on that moving forward, we're not going to be able to impact change. So you'll see this a couple more times. But again, everything we did, we tried to pull back into these three core concepts. So some of what we did was, you know, not rocket science, but again, getting to that, building a network, getting people talking to each other, getting people sort of sharing their experience, right? So we did a lot, we spent a lot of time doing icebreakers, right? And getting people in random groups. You know, when we were on Zoom, we were putting people out into random breakout groups and having them introduce themselves, where they work, and then answering one of these questions, depending on where we were in the icebreaker. And none of these are particularly brilliant questions, but they're not questions that people are asked all the time, right? And it really gets people talking about their experiences, the roots of their names, right? Where you're from, where are you living now? What's that like? We worked with folks who were living 3 blocks away from where they grew up, right? And folks who are, you know, on a new continent now from where they grew up. Having them think about their jobs. Are they similar? Are they different? What are the threads between health centers? Again, because we don't ever, when we're in the work, it's so rare that we get to look outside and say, oh, you do the same thing, or we have the same title, but we do really different things, which has been my experience. And then also thinking about mentorship and supervision and what that's looked like, what's been good, what's not been good, right? So again, getting people to start thinking about these different things as a group and build community at the same time. We also asked folks, we used Poll Everywhere, which worked really well. And people who couldn't figure it out could put it in the chat and we would put them in for them. And again, this was about creating, showing that folks are experiencing a lot of the same things. And when we did this in person, folks wrote this on a Post-it and put it up. And then Jenny and I just really quickly pulled the threads, but Poll Everywhere could do it for you. So for folks who haven't experienced a Wordle before, that's what this is. The more times a word is put into the poll, the bigger it will be. So you can see one word that makes health center work great: community, diversity, helping, commitment, patient-centered, teamwork, right? Those are the big themes that came up for folks. This is just from one session about what makes health center work great. And we really wanted to lift that up for people because health center work is great. We're doing it for a reason. We also wanted to reflect on what makes health center work hard: resources, communication, teamwork, burnout, time, funding, right? Overworked. And again, this is not to be depressing for folks, but to have them see that they're not alone in these experiences, and that no matter where you are in the state and no matter what health center you're at, you are also likely facing many of these things, and we can learn from each other about how to deal with them. So we also, when we built our content, so this was really, what I just showed you was really rooted in just giving people space to get to know each other, to start talking about their experiences, to lift up, again, the threads that bring us all together. But then we moved into sort of more traditional content. And what we wanted to do, again, was not just throw random content to people, but really take the time to give folks content and then continue to pull it back to self, team, and patient. So again, everything we did was rooted in self, team, and patient, even if we were just giving tips and tricks on how to do things well. So these are some of the things we talked about. I want to pause and say, Jenny and I aren't experts in all of these areas, right? And you'll see in some later slides, some of the days we had behavioral health clinicians join us, and they actually know more about this than we do, right? So it wasn't our intention to give expert information about all of these things, but again, really to lift up these concepts and help folks apply it to their personal experiences, right? And give some basic information about each of them and help them understand how that might impact their day-to-day life. So, for example, we talked about burnout and moral injury for a fair amount of time. And moral injury is not something that folks talk about a lot. And so what we wanted folks to do is talk about what burnout and moral injury looks like in themselves, right? So for me, I get really bad road rage when I'm burned out, right? I get really snappy. What does it look like when it's showing up in your team, right? What happens to your team when you're all feeling burned